Okay, how are people? It's noon here. Can you hear me?
Yes, we can hear you.
Okay, should I begin or wait or what's your feeling on it?
I'm good, but would imagine there'll be more people.
Okay, why don't we wait about 5 minutes?
Sounds good.
Now, perfect. Thank you. We're very excited. Our speaker today is James Seberger from Wichita, and also he's an ER physician for Emporia at Newman Regional Hospital. So we're very, very pleased to have him joining us.
Thank you very much.
Login folks, hang on just a second, Dr.
Sure.
Seberger. Remind people how to get their credits. We still got a few more people joining the waiting room. For those of you virtually, please make sure that your login is your full first and last name plus your credentials. That's the only verification that we have of your participation today for your continuing education credits. If you don't know how to do that, just let me know in the chat and I can help you with that. Let's see, a couple more joining. Today's offering, you will receive physicians 1 hour of AMA PRA Category 1 credits. Pharmacists or pharmacy techs can receive ACP pharmacy credits. Nurses will get ANCC nursing contact hours. Respiratory therapists through Levette Health will receive CEUs for respiratory care. Anyone else is eligible for a certificate of attendance as long as they enter the login code, which we'll talk about here next, into EADS and complete the evaluation. Doctor does have a couple of disclosures to mention that are projects in the works that aren't even really up and running yet. He will discuss that, and but all relationships have been mitigated. No one on our planning committee has any financial disclosures. And then this is the important screen you might want to take a screenshot of. Your EADS activity code is 09 FEOD. That is your activity code for today. It is a live active code in EADS through January 17th at 5 p.m. So make sure that you do that before then. There's a QR code there for the mobile app. Or you can text that code to 828-295-1144 or access the website. Either way, any of those three means will get you in there. And if you have any trouble with that, please let me know and I can assist you with that. And with that, I'm going to stop my screen share. And welcome and hand it over to Dr. Seberger.
Hello. Thank you very much for this opportunity. I would tell you I had a good introduction. I do work in the emergency room as my full-time paying gig. I have a practice in Wichita. It's clearly part-time. That's family medicine based. It's direct primary care. It's longitudinal, and I think as a practice model, it offers a lot of reward in its participation. I would tell you too that in private practice, we have to always be working to be ahead of the game and to understand what's happening to our patients. So just as a little feeler, I can't see you, but can you just voice if you are seeing patients that you think have long COVID? Okay.
In diabetes outpatient care, yes.
So about how many would you say you're seeing?
I would say at least one a month.
Okay. Do you think it's more or less than it was last year?
Tough to say. I couldn't say.
Okay. Okay. My feeling is it seems to be less as time goes on. I think it's still relevant. The country funded from the federal government quite a few number of long COVID clinics. Some of what they did I'll present here, particularly with low dose naltrexone. But so there's a lot of information in this, so it's dense, and you can stop me for any questions that you have. So presently, we don't have a laboratory test, though I'm working on this. Uh, Laboratory tests to get developed take, 2 years minimum, 4 years on average. And we're sort of left with clinical diagnosis of what long COVID is. And so this is a collection of symptoms uh, that have been put together. This is a reference from JAMA, but the World Health Organization also recognizes this. And it's important for us to have a description of what we think of as long COVID. And then, of course, we'll want to develop, verifying tests for that. But presently, we're here looking at the most common symptoms of known as a post-acute sequelae, or PASC. That's probably the more correct medical term. And the top 3 or 4 that we see are loss of smell or taste, post-exertional malaise, chronic cough, brain fog. These others receive a less of a score, but they're also pretty common. Here's those symptoms by frequency. And so there's a cutoff. When we add these up, we're getting a score of around 12. So when people talk about loss of taste or smell or post-exertional malaise, uh, particularly with loss of taste and smell, this is pretty specific for long COVID. Exertional malaise can be out of shape, can be other illnesses. Chronic cough can be sinusitis. Brain fog is pretty descriptive. There's palpitations. These fall into other illnesses. The most frequent of these symptoms, post-exertional malaise, 85%. Brain fog, dizziness, and gastrointestinal symptoms make up 60 to 65%. So what's the incidence? So this was based upon last year's data. Clearly, we've had continued COVID cases. I see 2 to 4 a week in the emergency room. I usually have a call from my patients 1 to 2 a week, particularly in this holiday season. In the United States, there's approximately been 104 million cases. Of these, about 10% is what we are expecting, what it looks like are developing into long COVID. So I've always interested in drilling down into the molecules. I'm an MD, Ph.D. A little odd to have been such a specific student of biochemistry to become a generalist like in family medicine, but I'm always very curious about, if I can, what are the molecules involved? So these are the things that we see. We see mitochondrial changes, pulmonary function changes, persistent viral infection. The protein lasts a long time, up to 900 days. It has alpha beta sheet configuration, makes it very, very difficult to degrade. There's changes in genetic expression, primarily through epigenetics, and then there's clearly autoantibody formation. So mitochondrial changes, really very well reviewed by Doug Wallace. And Douglas Wallace literally wrote the book on mitochondrial genetics. And he's been at the Children's Hospital of Philadelphia for a long time. I think he's retired now, but he did do a review looking at mitochondrial metabolic and epigenetic program in COVID. And he says the perturbation of mitochondrial bioenergetics and reactive oxygen species lie at the center of COVID-19 pathophysiology and results in alterations of mitochondrial metabolites that could modify the epigenome to suppress oxidative phosphorylation gene expression even after the viral genome has been eliminated. So he's talking about leaving a permanent mark on mitochondrial genetics. And we have mitochondria, which powers the energy, provides the energy in our cells, about 90 to 95% of our energy. There's 50 to 2,000 mitochondria in each cell, and they have their own small genome. And so here's, I'm just going to go through this and talk about, because we're physicians, we need to begin to treat, not just diagnose and stop, but diagnose and treat for a better outcome. This is a nice picture that shows oxidative phosphorylation and its perturbation that occurs in long COVID. So when we talk about brain fog and shortness of breath and post-exertional malaise, though there's autoimmune effects in post-exertional malaise frequently, we can really begin to understand that fatigue is a result of decreased energy production. And so these workers have identified in PASC that there's changes in mitochondrial function, and it changes the ATP that's produced, how it's produced, and the oxygen that's consumed. I'm going to go through those changes here. So what they find is there's actually increased proton leak. What happens in oxidative phosphorylation is protons are passed from the interior of the mitochondrial membrane they're passed through the different complexes, and they create, as you probably remember from your biochemistry courses, they create a gradient. That gradient is tremendous. It's on the order of 10,000 to 1. And with that, we use oxygen as an acceptor for hydrogen. So you pass hydrogen to oxygen to make H2O. And so oxygen drives that membrane. What's happening is there is leakiness in this membrane. And so there's increased oxygen consumption, but it's not creating the continued or the degree of gradient that was previous, and that's what this is showing. You can see this nice diagram here in A, then breaks this down to where the issues are in terms of what's happening. And you see this green arrow that's preceding it, and so we're having a leak. And so that's what each of these quantifies. They're showing that the ATP production is affected, mitochondrial respiration is affected, the spare respiratory capacity is affected, and so we're really having a problem with increased oxygen without producing energy. Okay. Here's this in a diagram. It shows basal respiration not really affected, ATP production okay, but we're having a proton leak, and we're having maybe a little increase in non-mitochondrial respiration. So what's causing this? The spike protein impairs mitochondrial function in human cardiomyocytes. So there's an underlying cardiac injury in COVID-19. What I will tell you in my practice, I've seen 2 patients in the last year develop pulmonary edema, particularly one, a 42-year-old man, had no reason, treated with medicine, had to unload him with diuretics, begin ACE inhibitors and spironolactone. Cardiologist did an echo, clearly diagnosed this as a viral-induced cardiomyopathy. Do I know that this was caused by COVID? I don't. I do not know that. But I've seen increased numbers of patients with this in my practice. And I suspect there's an issue with this. Here is human cardiomyocytes treated with the first part, that's what S1 is, the first half of spike protein, which is sufficient to cause the disease of COVID. You don't even need any of the remaining components, and Inderjeet Singh showed that, and I'll go through that data subsequently. But what we see in cardiocytes is very similar data in terms of what's happening with changes in oxidation production. Here's changes in membrane potential. It's increased at 24 hours, but subsequently, what you really see, all right, is 72-hour, there is a marked effect. You can clearly see the figure to the right, control, here's S1. This is increased, and then the amount of fluorescence is as a result of oxidative phosphorylation at 72 hours, there is a marked decrease significantly. And what they're seeing is changes in sarcoplasmic reticulum calcium release, which is important for myocyte contraction. So they also show that also at 72 hours, what is ultimately happening is we're seeing increased fragmentation and loss of mitochondria in the cardiomyocyte. And we're seeing increased reactive oxygen species at 72 hours, right? So there's a delay here that we see. And then these are mediated by binding to the angiotensin II receptor. And this is a busy side, but what the part of what I'll show here, I'll focus on, is they are looking at oxidation in terms of glycolytic ATP, mitochondrial ATP, total ATP, and they're doing this with control, the presence of an antibody to the angio2 receptor. Then with spike protein, we see that it decreases in all three cases, but this effect is abrogated, lost, when we add the antibody to the ACE receptor. And so what this is really showing is and it's not by another receptor. You see this right here. There's no change when you use a different type of antibody. It's an antibody specific to angiotensin II. So it's really saying that the binding of the spike protein in the first half, S1, is sufficient, is causing angiotensin II activation, and that you can block that with an antibody to show that it's a specific cause. Okay, so here's a nice, beautiful diagram that was put together. Here's the S1 portion of the spike protein. It can bind to the angiotensin II receptor, and it's clearly causing changes in reactive oxygen species, calcium release, decreased ATP production. Okay, so that's where we're seeing mitochondrial effects. It's a mitochondrial mediated illness. Okay, so is there a treatment for this? And the answer is yes, and it's metformin. Okay, so here is an article that was published in Lancet, and it says outpatient treatment of COVID-19 and incidence of COVID-19 over 10 months. And this, they tested ivermectin, fluoxamine, and metformin. They controlled it. It was blinded, sort of the penultimate study that you look for. And you see a 40% reduction at 10 months in the incidence of long COVID by using metformin. Let's see here. So this is metformin beneficial effect was consistent across these subgroups. And it's really saying start within 3 days of symptom onset. All right. Let's see here. So there, do we have evidence of the effect of metformin and angiotensin II? And the answer is yes. So it reverses the effect of angiotensin II in human mammary arteries by modulating expression of nitric oxide synthases. Fabulous. And then metformin attenuates the angiotensin II-induced TGF beta 1 expression by targeting hepatocyte nuclear factor 4 alpha. But this is, very beneficial to use. And what I would tell you and I'm going to go back to the picture here. And how does it do that? There's two places that metformin directly interacts in several studies. It's really inhibiting complex 1. Now, particular complex 1 production of reactive oxygen species. And it says 1, you see a nice gray blob there, right? I mean, okay, we have the idea that this is a single protein. But if you were to break this apart and look at it with this, do crystallization of this, really nerdy physical biochemistry, complex 1 is a very complicated protein that's made up of more than 50 subunits. And it's being changed in its composition on a minute-to-minute basis in the mitochondria. Cortisol, for example, will bind to its receptor and it will interact with complex 1 to produce more OH. So that's an example of environmental effects mediated through complex 1. Metformin attenuates that. In addition, there's another protein called NOX4 in the mitochondrial membrane. It's an NADPH oxidase, which also produces oxidants, OH being the primary one, and it is also inhibited by metformin. So I have gone to, with acute cases, prescribing a single, if there's no contraindications, prescribing a single metformin ER 500 milligrams, one a day for 2 weeks. And I know this is clearly a different disease than it was 5 years ago, but I don't have any deleterious effects, and I'm not having patients come back with a lot of long COVID symptoms. I would also say that my patients who had COVID and were on metformin at the time as part of their insulin resistance program, I'm not having long COVID symptoms with them. So kind of, clearly we have randomized controlled trial to fall back on. I think in practice, it's important to have some, sense that you can apply the trial. Okay. Now, some of the pulmonary effects are more concerning. And in SARS-1 and MERS epidemics in the last 20 years, and these clearly were smaller with a different disease with higher mortality, 13% and 30%. About 20% of survivors died within 5 years due to lung problems. And the primary lung problem that we see in long COVID is interstitial lung disease. Okay. It says alterations of gas transport may be present even in subjects who had mild COVID-19 pneumonia and no or minimal persisting CT abnormalities. So I think the important thing to do with your patients that have shortness of breath is get a pulmonary function test, right? Actually get some measures. And in this case, what we're really looking for is reductions in the diffusion coefficient of carbon monoxide. They give a little tiny bit of carbon monoxide. They're able to measure it in the test. And frequently, what we see is really marked decreases. So what I will tell you, and this is a case, now how do we treat this? The pathway of TGF beta, which goes up in fibrosis, in which I measure in my patients, again, I'm a direct primary care, so I don't have to bill insurance or go through a laboratory to billing insurance issue. It all is under, can be billed under a health savings account or flex spending account. It's about $170 for this to be obtained at, Quest, but I see increases. But TGF beta and its effect on fibrosis can be ameliorated with steroid. So in patients with reduced DLCO, I am treating with Advair, inhaled steroid. And here's an example of somebody who had, pretty consistently low DLCOs, okay, 58, 2021, 51, 2022, 47. And she came to me in 2023. So this was the test that I ordered. And then I put her on inhaled steroid and really got an improvement in this. You might also see reductions in total lung capacity. And so I think it's reasonable to use an inhaled steroid and we can measurably get some improvement. Okay, what's that? Oh, I can't hear you. I can't hear the question at all.
I don't think it's coming from this room.
Okay, okay.
Sorry, we're right next to another conference room that there's.
Oh, okay. So right here, we're going to talk about some of the cognitive effects, okay? So in this case, we're looking at MRIs that were obtained before COVID and after COVID, right? So it's an MRI brain bank. So it's a part of the UK's data collection. And what they clearly show in the pre and post-COVID conditions is a reduction in gray matter thickness and tissue contrast in the orbitofrontal cortex. So orbitofrontal is attention, executive function, and memory. And parahippocampal is clearly memory. And anterior cingulate gyrus also involved in attention. And these changes, you can clearly see changes in MRI and reductions of global brain size after COVID. And here are where these changes are occurring most pronouncedly. Z-score is a degree of standard deviation. So a Z-score of 3 is 3 standard deviations of change. So pretty remarkable. Where you see the yellow and red, there's really remarkable areas that are clearly impacted in the brain of long COVID. Function, right? So that we have patients who have had head injury, and we don't want patients to be their image or be their MRI. We want to actually measure function and improve function. And so this is looking at differences in cognition associated with brain change. Okay, and this is per age, and pretty stable here up until sort of the middle 50s. But then what it really shows is we have really an age sensitivity in terms of long COVID and cognitive changes. And the Mayo Clinic now believes or says or describes that 10% of dementia cases are the result of long COVID. Here is looking at PET scans in the brain before and after COVID in a long COVID patient. And we're seeing really a pronounced change in the brain stem. And we see that also with the QEEG data, where we are really having effects here. My belief is this is where the vascularity of the brain is very fine, and this is part of a vascular effect. Okay, here's long-term pathological effects of long COVID. This data is several years old, and they're previous infection accelerates the development of dementia. There's clearly impairments in elderly patients post-infection. We just looked at changes in cognition, and age is a risk factor for those. Risks of cognitive deficits, dementia, psychotic disorders, and seizures were increased even at 2 years post-infection. And then autopsy data shows in all cases diffuse white matter damage with diffuse microglial activation. It's worth spending a little time on microglial activation. In conventional Alzheimer's, microglial active, where there's a loss of synaptic connections, and we see changes in connectivity, both electrically and anatomically. In conventional Alzheimer's, we believe that is really driven by microglia. Microglia are the white blood cells of the brain. They represent about 10% of the cells on a cellular basis. Microglia are derived from bone marrow and during development migrate to the brain. And when they're activated through inflammation, they become hypersynaptic pruners and begin to prune the microglia, prune the synapse connections of the neuron, which leads to less and less connectivity. Okay, here's some more data looking at cognitive changes. And this is between 2 European countries, Germany and England. They did online testing, and they were able to really show that reaction times and number of vigilance tests, which is as a function of attention, were really dramatically changed. And they very, very well controlled for psychiatric comorbidities. And this is reaction time in seconds, no COVID condition. Here's post-COVID condition in Germany. Here's post-COVID condition in Oxford. They also showed reaction time changes. And these are Z-scores, pretty tremendous. If you think about 1 or 2 standard deviations here, there's clearly Oxford had a much more pronounced change in reaction time in a post-COVID condition. So people are slower in response. This is also looking very similar. It's the same type of presentation of the data. What we really see is, again, a change in reaction time in terms of Z-score and terms of seconds. People are slower after this. Their attention declines. All right. Also, these patients really were predominantly affected. There was female preponderance. 80% were women, ranging from 26 to 64 years of age, and they had processing speed, attention, executive function changes in 85% of participants. The authors attributed this, and I'll go into this, to possibly an autoimmune mechanism. Women have a much greater degree of autoimmunity that develops. And then here, I wanted to just look at some blood transcriptomic measurements. Now, in this case, this work was done in the Netherlands. And the work was done by taking blood from long COVID patients. So these are patients that fit from that criteria of loss of taste or smell, brain fog, persistent malaise. These patients were that group, and the goal was to identify RNA changes or expression changes in this group of people versus no long COVID. And they demonstrated these changes for up to 2 years. The change that they identified is a increase of a Src kinase called FIN. And when they detected FIN plus the presence of COVID RNA, then they identified that long COVID patients uh, had as a blood marker 93% sensitive and 91% specific. And this data is pretty impactful because you can look in the literature and multiple workers have identified the presence of COVID persisting for a long period of time. And it's likely that what's happening with long COVID is we're not clearing the virus. And here's that data in a graphical form. I think pictures 1,000 words. Here are all the RNAs that they're detecting. Here's FIN, right? FIN's clearly the most expressed in a log-term value, right? So 10,000 times more than down here. And if you put the detection of FIN with the detection of the virus, when you have both of those detections, you really can identify in the blood the presence of the virus in long COVID. So we have a possible explanation for long COVID. It's a continued infection by SARS and increased FIN expression. And FIN is connected to dementia. Here's a very thick reference article in which FIN and COVID and a membrane protein are clearly impacted and involved in Alzheimer's disease. And this correlates with what we see clinically. We're seeing increased dementia formation. This is another important paper, and what this shows is the expression of FIN is in the two regions of the CNS, the temporal cortex and the parahippocampal cortex. So there's a correspondence of FIN expression in the areas of the brain where we see cognitive decline in long COVID. All right. What continues to cause the disease? All right. So I showed earlier that just the S1 portion binding to angiotensin 2 can cause these mitochondrial changes in cells. And this work by Inderjeet Singh, and Inderjeet is a legendary biochemist. You may have heard of a movie called Lorenzo's Oil, and in that movie, Inderjeet, it's about him as the biochemist who works on peroxidation reactions and medium chain and small chain fatty acid synthesis to help unfortunate children that can't metabolize this. So Inderjeet is legendary. When grants are graded and scored, he does that. His work is number one. Literally, it's number one. He's worked on glutathione reductase for much of his career. And what I want to show you is just another treatment pathway in terms of ameliorating COVID and probably long COVID. And so these are some portions from that paper of his work. And so what he did is he developed a model of COVID without needing to be in a secure facility, right? And so he took the first half, the S1 portion of the spike protein, he put it in the nose of mice. And then 5 days later, he looked at the mice and he shows that there's all kinds of inflammation sufficient to cause methylene blue to be uptaken. But when he actually does an inhibition of glutathione peroxidase, or glutathione, not peroxidase, glutathione nitrate oxidase, when he inhibits that, he actually inhibits the effect of the protein. And so you may have heard that 4 or 5 years ago, we weren't allowed to sell NAC. I think it's probably correct to say NAC, which makes glutathione in the body, is not going to uh, stop COVID or cure COVID. But I do think that NAC and glutathione, in this case, a molecule of the inhibition of the glutathione reductase, I do believe that it would clearly ameliorate the disease. Okay. So in terms of long COVID and what I use with patients, I do use NAC, and I'll summarize at the end of this talk all the interventions that we can use, and one of them is NAC. So NAC supplementation has been widely explored, and it's been associated with lower mortality in patients with COVID compared to placebo group, with a decrease in CRP and D-dimer, and actually really an improvement in oxygenation, the partial pressure of oxygen to the fractional oxygen ratio. Okay, so really important components of this. One study found there was, if you treated with NAC twice a day in the presence of COVID, there was a 17% reduction in the progression to being on a ventilator. All right, let's go on to the last of these effects, also very important effect, and this is the autoimmune effect in long COVID. So there's clearly evidence of autoimmunity. It's analysis of COVID patients with antibodies specific to type 1 interferons was 5% of the total number of patients with COVID and 10% of patients with severe COVID. So there's an autoimmune component of the disease. And then here's really a real juicy nugget for providers to understand what's happening in patients with this post-exertional malaise and this tachycardic syndrome. So sometimes we call it POTS, positional orthotachycardic syndrome. In this case, it's really not positional. It really has to do with exertion. And so in a presentation at the Keystone Conference in 2023, a pulmonologist who was doing academic work, he took patients and he did intensive measurements. So he put them on exercise bikes. He cannulated their arteries so he can get the continuous arterial oxygen. He was able to get venous oxygen. The person on the bike is breathing in a fractionated portion of oxygen, and the CO2 is measured. And so the question is, what is really happening in this post-exertional malaise? People do something and then they can't do anything. And to summarize that work, and it's very fascinating, the people with this phenomena are preload dependent. And by that, when you look at your physiology that we learn in medicine, we learn that the heart pumps all the blood that is brought to it. And so what's happening with these patients is at rest, they have blood in their heart, but they quickly pump it out and they're not getting any more preload. And the implied mechanism, or the strongest mechanism, or a evidence-based mechanism, is there are functional antibodies targeting G protein receptors in the sympathetic nervous system, which are not constricting, and there's causing dysfunction of the sympathetic nervous system to the point that we can't get blood in have sufficient preload when we have the demand. Very, very, very fascinating. And so these are patients with an autoimmune condition. And this is a paper that describes that, functional autoantibodies against G protein coupled receptors. And this group did very painstaking work of taking blood from patients with this tachycardic syndrome, purifying the antibodies in little dialysis bags, and then they gave back these antibodies to mice and showed that they cause tachycardia. Super fascinating, super interesting. Okay, here's that in words. Sera from long COVID patients contained functionally active autoantibodies targeting G protein coupled receptors. They found that they targeted beta 2, alpha 1 adrenoceptors, angiotensin 2, and antimuscarinic and nociceptive and ETA receptors, kind of a whole potpourri of receptors. This included patients that had neurologic and cardiologic problems, and that such autoantibody patterns have previously been seen in COVID independent of neurologic deficits and cardiovascular disease. So is there a treatment for this? And what I would tell you is yes. There is evidence for the use of low-dose naltrexone in autoimmune disease. And so the use of low-dose naltrexone it actually has been one of pretty common in the long COVID clinics that the federal government has supported. And here's you usually prescribe it at 1.5 and then 3.0, then 4.5 milligrams per day. Most of my patients are just fine at 3, and I leave them at 3. And in this paper, they say the use of low-dose naltrexone was associated with a fewer number of symptoms, improved clinical symptoms, fatigue, post-exertional malaise, sleep, and abnormal sleep pattern, had a better functional status. So I have found this. I use this with my patients that have predominantly this tachycardic syndrome, but I've also found it to be effective in just sort of my fatigue patients as well. Here's additional, citations on the use of low-dose naltrexone and NAD+ for persistent fatigue. And, they find statistical significance in their study. All right. So what I want to just kind of put it all together so that there's we're doctors and we need to not just describe, we need to treat. And what I would say is most post-COVID patients have their own collection of problems. And I think it's important to treat patients individually. I just think all patients should be treated individually, honestly. So treat the virus. It's still present. Okay, it's completely reasonable to use Paxlovid. When I have a new COVID patient, I put them on Paxlovid. And Mario Castro, MD at KU, he's been using a 3-week course of Paxlovid, which is extraordinarily expensive, but I think valid because the virus is still there. Okay, and of course you have to pay attention to renal dose and medicine interactions, right? Know that once the virus, if it's cleared, the spike protein can have a huge long half-life. All right, it's binding to the angiotensin 2 receptor. Okay, and if you use NAC and or glutathione, or the inhibition of reductase, if you have that medicine, not commonly available, but you can get improvement in your symptoms. Okay, I use NAC twice a day. All right. I think it's very reasonable to treat with metformin. You can use it once a day. That's how I prescribe it. This is sort of a stop on the effects of mitochondrial dysfunction. Okay. I'm actually measuring reductions, 6-fold reductions in TGF beta by just one 500 milligram of metformin. I will tell you, I'm taking it for that reason. Okay, I have some long COVID effects, particularly tinnitus. And then if you have autoimmunity present, you can begin with naltrexone. This is a Schedule II substance. It usually has to be compounded. Most patients can get access to a compounding pharmacy. They can take this medicine for several months and stop it. If symptoms return, you can restart it. I have about 3 patients that I use this, and I've used it for years. Uh, it's really amazing when it works. If you have shortness of breath, malaise, exertional dyspnea, really it's reasonable to get a pulmonary function test and look for the DLCO. You can use inhaled steroid and then repeat the pulmonary function test to document improvement. I had patients with a sort of just post-acute COVID, maybe 2 or 3 weeks out. There's clearly a diffusion capacity issue. I put them on the steroid for several months until I measured that has abated, and then I can stop the steroid. That's what I've done so far. I'm clearly waiting for more evidence and more trials, but I think not doing something is worse than nothing. Is the worst thing than doing something. So if you have any questions, this is my cell phone number. I don't mind if you call or text, and you can also email me here. So I'm open to any questions.
Doctor, are you okay with attendees today receiving a PDF of your slides?
Yeah, I'm completely fine with that.
Okay,
Sure.
good. Because I've had a couple people in the chat ask for that, so I'll send that out later today.
Okay, very good. Yeah.
Anyone virtually have any questions they'd like to unmute and just ask directly? Not seeing anything in the chat.
Okay. It was a lot. I apologize. It was thick. I think it's a diverse illness. I think there are things that we can do about it in the primary care setting.
Very interesting. Thank you so much. We
All
appreciate
right.
your time.
Yep. Thank you. Thank
Thank
you.
you. Bye-bye.
Bye.